just want to say thank you for inviting me here. And I'm very passionate talking about insomnia because it's a really big prevalent condition, not only in Parkinson's, but just across the United States. Before we talk about insomnia, I'm just going to talk to you guys about what normal sleep physiology is, so we can talk about disrupted sleep. We're going to define insomnia, like what do we actually mean when we say insomnia. Finally, we're going to talk about assessments of insomnia, like how you should be evaluated, and describe the models of why certain people get insomnia while others don't. Specifically, then, we're going to talk about Parkinson's disease and the comorbid conditions that can contribute to insomnia complaints. And finally, we're going to discuss some of the treatments that have been tried specifically in insomnia and Parkinson's disease. So, when we talk about sleep, we also have to talk about all the centers of the brain that control wakefulness. So wakefulness is controlled through the brainstem, and dopamine is very important to promote wakefulness. And this is distributed widely throughout the cerebral cortex. And as Dr. Sutherland was mentioning, one of the first indications that someone can have Parkinson's is that they have degeneration in the dopamine centers in the brainstem. That's why a key feature of having Parkinson's can sometimes be daytime sleepiness because of this dopamine deficiency. So to counteract that wakefulness, how we initiate sleep is that there's certain substances in the brain that accumulate the longer you stay awake. And we call this homeostatic sleep pressure. The substance that accumulates in the front part of the brain is something called adenosine. And many of us can offset that sleepiness that we carry on the longer we stay awake by an adenosine blocker that we all have every morning, which is called caffeine. The idea of homeostatic sleep pressure can be similar to almost like putting on a backpack when you get up in the morning. And throughout the day, the longer that you stay awake, putting very heavy stones in that backpack. So later on in the day, if you stayed awake for a very long time, you're going to be really sleepy. That backpack's going to be really heavy. However, if you take a very long nap in the afternoon, it's like unloading that backpack. And we've all experienced maybe having a 2-hour nap late in the afternoon, and then you can't fall asleep till really late at night. A second mechanism that we use to offset that homeostatic sleep pressure is something called circadian drive, or circadian alertness. And we are all familiar with the advice of avoiding bright lights at night. The reason that is encouraged by sleep specialists is because melatonin is a hormone of darkness that starts to get produced when the sun goes down. And this circadian drive, which is high early in the morning, is reduced in the early evening once melatonin is being produced, and melatonin abates by the morning time. So you can think of wake and sleep as a seesaw, so that when circadian drive is high, you're awake. When the circadian drive is low, you get sleepy late in the evening. That's what should happen. However, in Parkinson's, a lot of this circadian drive is reduced because we don't make as much melatonin as people who don't have Parkinson's. And that's another very important feature of some of the sleep problems that are associated with Parkinson's. Now, sleep can have profound effects on your health. It can affect your heart, your memory problems. In Parkinson's specifically, it can affect, like after having a bad night of sleep, you can have more tremor the following day. You can feel more mentally foggy. And also it can affect your mood. It can also affect things like your blood pressure and your metabolism, how your body handles glucose, for example. So we're all aware that sleep can affect your health in many, many ways. So what do we mean by insomnia? There's some terminology that can get a little fuzzy and a little bit confusing. Insomnia symptoms basically means that you have difficulty either getting to sleep, staying asleep, or waking up too early. When we talk about insomnia, there's also time definitions of how long these complaints have to have been going on. Typically, we call it acute insomnia when it's less than 3 months, and chronic insomnia when it's been going on for more than 3 months. The other very important thing to talk about is when people are having these complaints, to make sure that there aren't other explanations for it. For example, Maybe where you sleep is very, very noisy. Maybe your home is next to a highway, for example. Or maybe there are other untreated conditions, like maybe you have untreated sleep apnea that's causing you to wake up frequently during the night. So these other things have to be excluded when we talk about an insomnia diagnosis. Now, more recently, we talk about insomnia disorder, and the main difference between insomnia symptoms and insomnia disorder is that these nighttime complaints have to be accompanied by a daytime impairment. So that nighttime complaint has to affect your day in some way, shape, or form. And as you can see, these are very kind of broad impairments, everything from irritability to just being tired to even having accidents, car accidents or accidents at work. Now, there's different assessments that we look at someone's insomnia complaints. Some of them can be like a sleep diary that you can fill out on your phone. You can obviously have a diagnostic interview where you talk to a sleep person or to someone who knows a little bit about sleep, just about your sleep habits, your patterns, what time you go to bed, if you take naps, how often you exercise, any coffee you might intake, other behaviors that can affect the quality of your sleep, like drinking alcohol, for example. There are many insomnia questionnaires that we use that are validated for studies. Sleep diaries, like I was mentioning, that can be paper or pencil, or that can be automatically programmed into your phone. And there's other objective measures of sleep. We use things like actigraphy, which are these rest activity monitors that can record your sleep over many, many days. As you guys may know, people who have insomnia do not necessarily have poor sleep every single night, but it's just a bad pattern of sleep overall. So you might have like 2 good nights, followed by 3 poor nights, followed by 2 good nights, et cetera, et cetera. So this sort of longer tracking of sleep helps us detect patterns that might not be that obvious in just speaking to someone. So what you see here on the left-hand side is someone with a normal sleep-wake rhythm. You see how regular the sleep times are and the waking up times. The black bars detect level of activity. You see that someone on the left is very active throughout the day. And you see on the right-hand side that someone with insomnia has a much more broken pattern. They're very active in their sleep. Their wake times are quite irregular. They're a little bit all over the place. So this is really helpful to sort of have this objective pattern so you can identify behaviors that the person is doing, like, for example, having a lot of napping here. You can see these episodes during the day where the person is napping, which sometimes people are not aware when they report these things to you. Now, sleep studies may also be indicated if we are suspecting that other comorbid sleep conditions are going on, like sleep apnea, which is very common as we get older. There may be other things like jerking their legs in your sleep. There's something called restless leg syndrome that I'll talk a little bit further about later. So sleep studies may be required if there's indications that there may be more things than just insomnia going on, and that these other comorbid sleep conditions can be contributing to the awakenings that the person is having during the night. Now, this is one of the most popular, I would say, models of why people get insomnia. The idea is that certain types of people are predisposed to getting insomnia. This means that maybe you have like a subclinical level of anxiety going on, and then there's a precipitating factor. It tends to be like an acute life event that initiates the insomnia. Like perhaps you get a divorce, or there's a death in the family, some very stressful emotional event that offsets the insomnia. Then the person develops certain coping strategies to deal with the daytime repercussions of that insomnia. So you're very tired during the day, so maybe you start taking naps, you start drinking a lot of coffee. You start also developing a lot of cognitions about your sleep or worry about your sleep. We call this rumination, sort of negative thoughts that go across your head, thinking things like, well, if I don't get a good night's sleep tonight, then tomorrow I have a big meeting, I'm not going to be able to perform at this meeting, or have a big talk and I'm not going to do very well at this talk. So you can really sort of work yourself up into a tizzy, and this is very sort of counterintuitive to relaxing and getting a good night's sleep. And even when the acute stressor is removed, maybe now you've gotten a new job or you're feeling better, these perpetuating factors keep the insomnia alive and keep the insomnia going. That's why some of the treatments that I'll talk about later for insomnia really target these behaviors that are contributing to the insomnia. So insomnia is incredibly common. About 15% of the US population suffers from chronic insomnia at one time, and it's even more common among people with Parkinson's disease, depending on how you define the insomnia. But it can be as high as 80% of people. I always like to put this elephant picture because sometimes physicians and providers don't really know what to do with insomnia, and which is part of the importance of having this project for Neuro Challenge. Insomnia does vary over time, and as usually the disease progresses, insomnia rates go up. Now, this is a study that looked at the evolution of insomnia over time, and patients were followed for 5 years. Controls are patients without Parkinson's, and individuals with Parkinson's are in blue. What you can see on the left-hand side is that over time, insomnia rates went up in both groups. But when you looked at the type of insomnia complaint, which is on the B figure, you see that maintenance insomnia, or waking up during the night, became much more frequent in Parkinson's disease over time compared to those without Parkinson's. And difficulty initiating sleep, or sleep latencies, actually went down over time. So what this really shows is that most of the insomnia complaints in people with Parkinson's is waking up during the night and not being able to fall back to sleep. So there's many reasons why insomnia is more common in Parkinson's disease, and there's a lot of depression and anxiety that can be comorbid with Parkinson's that contribute to insomnia. A lot of the motor symptoms during the night can actually awaken people during sleep. So for example, if some of your Parkinson's medications are running out, you may experience like painful cramping or dystonias that can awaken someone out of sleep. Now, also having to go to the bathroom and pain can be part of some of the non-motor symptoms of Parkinson's disease that can also interrupt with sleep. Importantly, many medications that are routinely used to treat Parkinson's can also influence sleep. So sometimes things like amantadine or certain types of antidepressants can have insomnia symptoms as a potential side effect. So doing a very thorough medication review is particularly important. Finally, things like behavior, like a lot of napping, like I was talking about before, and lack of physical activity can also contribute sometimes to poor sleep at night. Finally, there is a lot of certain types of sleep disorders, like restless leg syndromes, that can be creepy crawly sensation that someone gets while they're immobile late into the evening, that can present with a lot of difficulty falling asleep. That's about 30% in patients with Parkinson's compared to about 10% in people who don't have Parkinson's. A lot of other parasomnias are very frequent. There's something called REM sleep behavior disorder, which is acting out your dreams, and this can be very violent behaviors. People can even fall out of bed, and I'm going to show you some videos about this. And of course, there's the circadian aspect of sleep that can be impaired in patients with Parkinson's. Now, this is just a slide to remind you that the dopamine is what you see in blue, that it's projecting throughout the brain. That dopamine is not only important to promote wakefulness during the day, but it's also important in coordinating some of the sleep stages as we transition from one stage to another. And for this reason, the dopamine deficiency also impairs some of that natural progression of sleep staging. Another important physiologic aspect of sleep concerns rapid eye movement sleep, which is about 20% of the sleep period. What should normally happen during rapid eye movement sleep is that all of your muscles should be paralyzed, because you obviously do not want to act out your dreams. In patients who have Parkinson's, this part of the brain doesn't work as well, and it allows patients to act out very violent, sometimes very vivid dreams. And a lot of injuries can result from this. And that's what the videos I'm going to show you about, two different examples of rapid eye movement sleep. This is happening at 2:20 in the morning. So a lot of fractures can result from this type of behavior, and it can also be very disruptive to a bed partner, as you can imagine. Show the next one. So you can imagine how if this is happening very frequently, it tends to happen more early in Parkinson's disease, and it tends to abate when you get into the more severe stages. But if you're someone's bed partner, you'd be, this would disrupt both person's sleep, and there can be almost a fear about going to sleep when this is happening very often. This can result in fractures and subdural hematomas, contusions, and a lot of comorbidity. So really, insomnia treatment approaches have to do with, number one, addressing the comorbid conditions that are contributing to the nocturnal awakenings and any contributing factors that can be identified. If those things are addressed and the insomnia persists, then we go on to talk about insomnia-specific treatment. And that largely falls under two broad categories, whether you want behavioral treatments or you want medications, or both. And this is a joint decision that has to be discussed with your provider. For some people want totally behavioral treatments, some people want medications. And there's pros and cons to both approaches. For one, behavioral treatments may take a little longer to take hold. However, it's maybe safer over time. Medications tend to work a lot faster, but that comes at a price, which is side effects. For the non-medication kind of treatments, the first-line treatment for insomnia is a behavioral treatment called cognitive behavioral therapy for insomnia, and I'll just refer to it as CBTI from now on. Light therapy, and we'll talk about why that works, and finally, different forms of exercise. So CBTI is a multidisciplinary, kind of multimodal behavioral approach that attacks a lot of different things that are contributing to someone's insomnia. It attacks some of the behaviors that I was talking about before by including sleep hygiene, so making sure that you're exercising at the right time, you're not drinking coffee, you're not doing anything other than having sleep or sex in the bedroom, and it tries to break off a lot of the negative connotations that someone who's having a lot of sleep problems has associated with their bedroom. It also challenges a lot of the cognitions or the sort of negative beliefs that someone develops over time when they haven't been sleeping very well. And again, it uses physiology to match that person's sleep time to the time that they spend in bed. That's a very common practice that someone with insomnia tries to use to get more sleep. That's actually quite counterproductive. And this next slide shows you. We do something called sleep restriction, which is essentially giving someone a specific prescription for the time they spend in bed. What you see here is that when someone develops chronic insomnia, the natural sort of response is to try to spend more time in bed, and that actually makes your sleep even worse. So what we do is that we try to restrict that amount and make someone very sleepy and widen that window over time. However, as you can see here, it can take several weeks to work, so someone has to be patient. When someone sort of wants it fixed right away, this is not the best therapy for them. However, long term, this is a much safer and more effective therapy than using sleeping pills. And this can be delivered in different forms. You can do one-to-one sessions with a sleep provider or a psychologist, but there's actually self-help books and online forums where you can do this. And I'll give you some resources at the end. There have been very few studies that have been done in Parkinson's testing this therapy and have been found to be quite effective and very large treatment effects. And this reduces someone's sleep complaints drastically, and it increases the amount of time they get at night. So both the face-to-face therapies have been tested and online versions of these therapies. Now, this is going back to circadian timing and how circadian clock is very important for sleep. One of the things that does happen in patients with Parkinson's is that the peak melatonin that we make at night is not quite as high, and it's not quite as regular. Another circadian signal which is very important for sleep, which may be weakened in patients with Parkinson's, is how much physical activity they get. So both of these things really contribute to a weakened circadian drive and may contribute to not having quite as regular sleep at night. The strongest signal, though, that our brain gets to have the circadian drive is light therapy. And light is used to try to consolidate your sleep at night. And there's been different types of protocols that have been shown to be effective. Basically, this is using these light therapies that you see here. This is the same type of treatment that you may have seen for seasonal affective disorder that people up north receive when they're not exposed to a lot of sunlight. There's been studies that have shown that if you use these lights about an hour before you go to bed, it helps consolidate your nighttime sleep. So what's really helpful about this is that, number one, it has no side effects. These lights are not very costly. You can get these on Amazon Prime, actually. So it's a really helpful non-medication way to improve your sleep. You can see the effects of this. This is like a sleep diary that shows consecutive days. The light therapy is adjusted here in the first 2 weeks. These black boxes are continuous sleep. And what you see is after the light therapy is applied, that this person starts having more regular sleep. You can see that after a month, it's not like the person's having 7-8 hours of continuous sleep, but you see that there's less gaps in between those boxes, okay? Now, exercise has also found to have profound effects on sleep and insomnia. The type of exercise seems to be less important. So different things like resistance training 3 times a week, jogging mildly 3 times a week has been shown to be quite effective. And other things like Tai Chi, yoga have also shown to be of equal efficacy. And the effects are actually similar to what has been shown for sleeping pills. Now, there's 2 general approaches to using sleep medications to help improve sleep and PD. One is using long-acting forms of dopamine stimulation, like things like long-acting dopamine, particularly if you're having a lot of nocturnal awakenings from cramping at night or from dystonias at night. A second approach is just using more typical sleeping pills. There's been very few studies testing sleeping pills in Parkinson's disease and insomnia per se. The 3 medications that have been testing is something called doxepin, which is a very old antidepressant that has a lot of antihistaminic properties, melatonin, and isopicolone, that you guys may recognize as the brand of Lunesta. Although all of these work, you also have to consider that about 50% of people end up having side effects from these medications, and they're pretty typical side effects that you would expect from sleep meds, like somnolence, having lightheadedness, wooziness, and just feeling a little bit hungover, if you will. So there is an important discussion to be had about what's the risk versus the benefit of such medications. This is actually a figure that we included as part of this manuscript that was published last month, and it basically shows an algorithm for providers of how to assess insomnia, what factors to consider, and what medications to potentially try with someone or what therapies to try. And what you see here in the treatment portion, which is the second half of the figure, is that we really suggest trying behavioral options first, like CBTI, exercise, and then going to potentially medications. And we highlighted which medications have specific data for Parkinson's disease. In areas where we couldn't find sufficient evidence for Parkinson's disease, we used the existing evidence of patients who just have insomnia disorder without Parkinson's. But this is basically a guide tool for providers of what to do with insomnia and Parkinson's. So finally, I'm just going to wrap up some take-home points. Really, insomnia is quite complicated, and as you can see, there's a lot of things that contribute to insomnia and PD. And it may require some in-depth evaluations like sleep studies or sleep logs. And there are several treatment options that we have data for, but definitely larger studies need to be done. A lot of different types of sleeping pills or a lot of other types of therapies that are effective for insomnia in people without Parkinson's really have not been explored, and it's a huge unmet need. And finding someone that feels very comfortable dealing with these types of complicated issues is really key. I have given you some insomnia resources here for those of you who may be interested in seeking help. The American Academy of Sleep Medicine has a great website where you can find providers to deliver CBTI. There's also self-help books that are available. There's some free apps like CBTI Coach that you can download. There's also some commercial online services. Sleepio.com and My Shut Eye are very good. But my favorite, which is my favorite price, is this free online CBTI that was actually developed by the Department of Veteran Affairs. It's called Path to Better Sleep, and it's publicly available. And that's the website if anyone wants to check it out. And finally, this is a copy of the manuscript that was published last month in Movement Disorders Clinical Practice. And I just want to say thank you to Neuro Challenge for the invitation and for taking on this very important project. I will be hanging out here on the side if anyone has any specific questions and wants to come up and talk. Thank you.